Okay, happy Wednesday, October 31st, 2018. Happy Halloween to those of you who recognize pagan holidays. My name is Brad Burge. I'm the Director of Strategic Communications for the Multidisciplinary Association for Psychedelic Studies, otherwise known as MAPS. This is the third in our 7-series set of webinars that we're doing this fall and this winter. Thank you so much for joining us. If this is your first time joining us for one of our sessions, Bia, would you mind muting? Thank you. I just want to introduce you real quick to the platform. If you haven't used it before, up at the top of your screen, there's a few buttons. One of those is a mood button. You can indicate your mood during the session. You can indicate how you're feeling, and then we can all see those little emojis flying across the screen. A cool way to engage. We're also going to be doing a question and answer section at the end, about half an hour, once Paul and Alicia have finished their presentations. Please submit your questions via that question box up at the top of the screen. There's a button. And then we'll be collecting those questions and answering as many as we can at the end. Any that we can't answer, we're going to also try to get answered and send those answers out along with the video recording when we're done. So this is being recorded now, and if you're registered for the webinar, you'll be able to access it and view it later on. We'll take about 2 weeks to process it. A couple other tips: make sure that you have other programs on your computer closed. That helps save bandwidth. If you are experiencing any problems that keep coming up, I suggest just closing down the AnyMeeting app or your Chrome browser and then starting it again. We found that solves about 95% of the problems with it. Then if you have any questions about the webinar, either while it's going on or after it's done, I invite you to email us at events@maps.org. That's EVENTS@maps.org, and we'll get back to you as soon as we can. And right before we get started, I'd just like to invite everybody who's here. We have over 60 attendees here right now, and over 300 registered for this webinar series, so super exciting. I just invite anybody who's here to share where they're coming from, where they're located right now, city, state, country. We'd love to see the diversity of people joining us for these webinars. So thank you so much. I am just going to hand it over right now to my amazing colleague, Dr. Bia Labate, who's helped curate this content and will be moderating for us today. Bia, thank you so much for joining us again, and over to you.
Hi, Brad, and hi, everybody. And it's great to be here again. My name is Bia Labate. I have a PhD in anthropology. I am public education and cultural specialist at MAPS, and I'm also executive director at the Chacruna Institute for Psychedelic Plant Medicines. We are hosting this webinar, and I'm giving a little intro about what the webinar is about. So the idea of the webinar is to make scientific knowledge more accessible to a wider public and, speak beyond the walls of academia, and also in more depth than just regular media. So a kind of balance that, have people be able to understand a little bit the backstages of research and the challenges, and hopefully influence you that are looking for career opportunities, or maybe thinking of changing your focus and dreaming about doing some psychedelic research, to see how fun it is, how challenging it is, and what kind of vibrant community we have. So it's an opportunity to talk directly to the researchers and ask questions to them, find out, how they made decisions they made or the challenges they faced, and also perhaps give feedback to them on future topics of interest or perspectives that might be missing. Try to make this dialogue, although of course the format is limited, but we'll try to do the best to accommodate all the questions that we have. And today we have a dear topic to a lot of us in the psychedelic community, talking both about MDMA and psilocybin. So first we're going to have our presenter, Alicia Danforth. She's a clinical psychologist, and she has, I think, over a decade, maybe since 2006 or so, been doing all kinds of different research. Originally very discreet and a little bit off the cameras, and we're all happy that she's appearing more out there, although she keeps her more reserved style, but she's definitely a rising star in our field. She has studied the topic of social anxiety with autistic population, and she has also studied psilocybin and cancer-related anxiety of death of end-of-life anxiety. And she has also is doing another research that is currently happening with older gay men in the Bay Area that have demoralization due to the AIDS, the HIV epidemics. And excuse me all for my mistakes in English. This is part of the the diverse voices of this webinar that I'm not native speaker and sometimes I miss the words. But anyway, she can explain better in her own words her CV. And next we have Dr. Paul Hutson that is from Wisconsin, and he's going to talk about the Wisconsin psilocybin study in normal volunteers. I guess normal is people that are not sick. Anyway, he is an expert in pharmacokinetics. I guess you can ask him what that means. And also in psychedelic research and clinical research. He has a practice in palliative care, and he's a professor of pharmacy at the pharmacy practice at the University of Wisconsin School of Pharmacy in Madison. And I just want to remark that perhaps Dr. Paul has not been, attending so many conferences yet. And the voice of this whole team, because it's not only him, it's a team of people, is perhaps not so visible on the psychedelic circuit. They have been also doing their work kind of discreetly. It has impacted the field a lot, but perhaps it's not so visible out there yet. And it's also part of, our pleasure today to bring this news on this research. So with all that said, I just want to give an extra thanks to our speakers and remark that they are donating their time. They're not being paid for this. It's a pro bono work in the name of psychedelic research. All the funding of this webinar is being reverted back into research on psychedelics. And so thank you very much, Alicia and Paul. And we're going to start with Alicia, and after her we go to Paul, and then we have questions and answers. Thank you.
Thank you, Bia. Okay, there are my slides. I'll go ahead and mention I have a very quiet dog who never barks, but the minute this call started, my dog in another room started barking. So my apologies, I can't put him on mute. I'm very excited about this presentation because Max has provided me with an opportunity in this webinar to talk about the stuff that I really care about and rarely get a chance to share with others. Bia mentioned that this webinar format gives us an opportunity to go backstage, and that's what I'm hoping to do for you today, to give you some insight into one of our absolutely crucial critical success factors for this first study with an adult autistic population with MDMA-assisted therapy. We had a secret, I won't say weapon, but strategy that really contributed to the success. And Brad has certainly been a witness to that. As Bea mentioned, I am a psychologist. I'll just state at the start of this talk that I loved working with this population so much that when the study ended, I didn't want to stop working with them. So I now have a private practice in Los Gatos and specialize in working with adults whose autism isn't necessarily readily apparent when they first walk in the room. We're not working with people who experience severe disability that's overt. They are able to get an education, they have skills, but the social anxiety and the social challenges of autism get in the way. So that's the population we were working with. So to dive right in here, I'm going to take you back to the very beginning. I want to introduce you to a colleague that was instrumental in making this study a success. This is Nick Walker. He has a degree in counseling psychology from CIIS in San Francisco, and he's currently working on his PhD. He is an autistic self-advocate and scholar and author. And our meeting was strictly by chance, I didn't see it coming, a mutual acquaintance said, "Hey, would you like to give a salon presentation in the city about autism and psychedelics?" He knew I just started work on my dissertation research, which was about MDMA and ecstasy use in non-controlled settings. I just wanted to find out what happens when autistic adults use ecstasy or Molly. And we met at a Thai restaurant, and there's a photo of the little table where we had several auspicious meetings that came to inform how the research was conducted on a very deep level. So this is where it all began. And let's see where it went. Nick and I presented at a salon, which was my first introduction to the concept of neurodiversity. And we'll go into what that term means in a little more detail in a moment. But I was so captivated by hearing his accounts of psychedelic use in his youth that led him to pursue martial arts as a means of integrating those insights. He knew after his experience with psychedelics, he didn't want to keep using them, and he used Aikido as a means to carry those altered states of consciousness forward and integrate it into his life so that they could become sustainable traits. And he's now a 6th Dan Aikido master with his own dojo in Berkeley. But after doing that salon, I realized there really was something to this neurodiversity concept. This is from Nick's website, where he defines neurodiversity as the diversity of human brains. Put simply, human brains are different. And from the very beginning, he helped me adopt the attitude that autistic self-advocates use to conceive of autism as a difference instead of a disorder or a disease. It definitely entails disability, but taking a less pathologizing approach to the autism and looking at the data from survey and interview research from the dissertation study, it became apparent that what we needed to focus on was social anxiety and not autism. This is a social anxiety study, not an autism study. Here's a little more detail. I would recommend, if you're interested, to come back and review this definition in more detail on the slides that'll be available, or I can make this content available later. Okay. I refer to Nick's website there. So, Landon Bryce is an autistic educator who had a website for a while, the Thoughtcast, of topics of interest to people who are interested in autism. And this slide represents a sample of 100 people in the general population, the bright yellow being allistic or non-autistic individuals, also referred to as neurotypical. And out of every 100 people, about 1 or 2 of them will meet the diagnostic criteria. There's no more Asperger's diagnosis. It's all under one umbrella of autism spectrum disorder. But this slide, I like to present it because it makes the point that there's this broad autistic phenotype of individuals who may have some traits but don't meet the full diagnostic criteria. So as a result of working with Nick, it became apparent that we needed to hire him as a member of the research team. He's also one of the authors on the paper, and we consulted with him extensively, as well as other members of the autistic community. But I don't use person-first language. We don't say a person with autism, because the preference in the population we were working with was to use identity first, to just use autistic as an adjective. I learned a fair amount about ableism and could see the preferences towards ableism in psychedelic science and could start working against that. We don't use functioning labels. We don't refer to the people in our study as being high functioning, because the first time I used that term in front of Nick, he leaned in and looked me in the eye and said, "High functioning relative to what?" And so that made the point that we don't refer to people as high and low functioning. We don't use the term nonverbal. because that means without words, and a lot of autistic people who do not speak opt to do so because it's uncomfortable or difficult, but that does not mean they are without words. They may be highly verbal. I became aware of the concept of intersectionality because there's a much higher likelihood that individuals on the spectrum will also be gender nonconforming individuals. There's a higher likelihood that females who are autistic will opt to transition female to male. So we had to also do our homework and be prepared to support people around issues of gender diversity and sexual diversity. And an important point before I go any further is we were not in any way trying to provide empathy to people who lack it. It's a myth. Individuals on the spectrum are often highly empathic. That's a conclusion that a lot of people jump to, that because MDMA is an empathogen, that we are somehow trying to instill empathy by clinical treatment with MDMA. That's not the case. So I included this post when Nick posted about the study on Facebook when we published. He was sure to point out the importance of the involvement of community-based participatory research. And I'll show you some of the ways that it really was advantageous. MAPS made a very smart move by including Nick and making sure that we gained buy-in. I'm aware of another study at a prestigious university where they neglected to work with community members, and the study wasn't able to complete because they got community backlash. So anybody who's interested in doing clinical research with any marginalized populations, I highly recommend working with the community as researchers and team members from the outset. Here are a few additional points. I would like to, before we move on, make the point that it's very important not to engage in this type of community engagement strictly for the purpose of exploiting community members for recruitment access. That's a big no-no. Include them on the team as full and equal members of the team, and consult frequently for protocol development all the way through publication. It'll improve the research, trust me. So I've made the point we were treating social anxiety, not treating autism. We were working on helping individuals improve social adaptability. Social anxiety is very prevalent, not only in the autistic population, an estimated about 7 to 12% of the general population also experiences social anxiety. So this research, the next step after completing the pilot study will be to include a larger population of individuals who aren't necessarily autistic in future studies. And most of the individuals we were working with, their autism wasn't necessarily readily apparent when they first walked in the room. But that increases social anxiety because they're expected to understand and conform to the social norms. So social anxiety was often was moderate to severe. I mentioned the dissertation research. There was extensive qualitative research done in advance of starting a clinical pilot. I would recommend, anytime anybody has the budget and time and resources to do so, to engage in robust qualitative research to really understand the population you want to work with and learn about their subjective experience. These were some of the themes that came up working with autistic adults. They reported increased courage, improved communication in multiple domains, an enhanced sense of connection, maybe being able to feel connected to a group of people or a bigger cause, that rises to the level of feeling communion. That could also have spiritual overtones. But the most remarkable finding, the difference between neurotypical populations and autistic populations that I did not anticipate. Autistic individuals frequently report a profound sense of calm and mental clarity while experiencing the acute effects of MDMA. They'll say things like, my thoughts straightened out in a way that I'd never experienced before. I think that's an area that merits additional future research as well to find out why that's the case. So we did conduct a pilot study. I'm not going to go into great detail because MAPS generously made free open access available to anyone who wants to download the findings paper that was published in this September. I think there's a link that this is available to you through this webinar. We also published in 2016 a rationale paper that goes into great detail about the background, and anybody that's interested in the pharmacokinetics and so on can access that paper online as well. We were assessing feasibility and safety, and the goal was to estimate the placebo-subtracted effect size. N of 12, randomized, double-blinded, placebo-controlled. Everyone received 2 MDMA-assisted treatment sessions within a brief course of psychotherapy with a 6-month follow-up, and vital signs were collected for safety throughout. We had autism status confirmed by an independent rater who completed a gold standard evaluation, so we could make a claim that everyone, in fact, met the criteria for autism. Everyone was 21, MDMA naive. They had to completed 2 years of college or the equivalent as a means of assessing their readiness to participate in a pretty rigorous study, and everyone was able to speak. We had 1 primary psychotherapist, that was me. Dr. Charles Grobe was the other therapist. He's the psychiatrist at the Harbor-UCLA Medical Center at LA Biomed, where the study was conducted. So we used the traditional male-female dyad, and data from the dissertation research indicated that the standard dose for neurotypical MDMA users might be a little overstimulating for autistic individuals. So we had 2 groups. The first group of 4 received 75 milligrams. If they tolerated that, they went up to 100. The second group of 4 started with 100 milligrams MDMA, escalated to 125. Everyone tolerated all of those dose levels well. And we learned a little bit about the differing therapeutic benefits of the lower range dose and the higher range dose. The therapy we used, dialectical behavioral therapy, originally developed for individuals with a borderline personality disorder diagnosis, was intended to provide some skills to help increase interpersonal effectiveness, emotion regulation, and distress tolerance. And the reason we chose this type of therapy is those are domains where autistic individuals also struggle. But conventional psychodynamic psychotherapy, there was no research to support whether or not that was effective for autistic adults. And there were just a few studies that showed mindfulness had been helpful with adolescents on the spectrum. So we went with that, and it turned out to be a real good match because those skills also help people enter an altered state of consciousness for the first time. The therapy sessions were a combination of the traditional headphones and eye shades model, but that really wouldn't be sufficient for a social anxiety study to just go within the whole time. So we had a combination of going within and interacting with the therapists. So one advantage of community engagement, we got a lot of consultation on how to set up the room so that it would not exacerbate sensory hypersensitivities, so that it would be a soothing, calm, and safe feeling environment. Couple of elements that we learned about by consulting extensively with autistic adults. There's a list there. One I like to call out is we were very careful to make it feel like an adult space because autistic adults frequently show up for treatment and it looks like a pediatrician's office, and we didn't want that to happen. many of the features of set and setting that we learned about to support autistic adults have also carried over. I'm implementing many of them in our current study with HIV long-term survivors. There were just some really good ideas. An example would be autistic individuals often rock and flap and fidget a bit to help regulate overstimulated nervous system. So we would have lots of little stim objects. And one of our study participants told me about this website, stimtastic.co. And I love their motto here, because stimming is what we do. That's just a little bit of autistic pride there, saying there's nothing wrong with stimming. And in fact, we encouraged it and learned that it's helpful for anybody experiencing the effects of MDMA when they get jittery, but in a dance club setting where they can get up and dance around, it gave people something to do with that nervous energy when it came up. So this is a great website. We also had to learn ways to modify the way we communicated to be supportive of autistic style communication. This little deck of cards, Mixed Emotions, was a great tool. Sometimes when people are entering an ineffable state with MDMA, we would invite them to draw cards. And these are 3 cards that, this was from an actual MDMA session. They weren't always this cheery and happy. Sometimes difficult content came up, and having a visual means of describing affective states was very helpful. And this convention has been carried over into another research setting, proved to be very effective. Using artwork, some individuals were much better able to express themselves in drawing and art than verbally. And this was from a visual diary that we invited participants to create at the end of their session as part of integration to help them carry forward and remember insight from the treatment session. For those of you who like numbers, quick qualitative finding slides. Did this study work? Yes, we had a very large effect size. And in fact, in editing the findings paper, a reviewer at MAPS kept editing out the word very large from the manuscript. And I had to put it back in and cite Solovsky's 2009 paper that added very large as the technically correct term for a Cohen's-D effect size of 1.2 or higher. We saw an effect size of 1.4, and that's the magnitude of change. Was it a small change or a large change? From baseline to end of treatment, we saw a very large effect size, and that was sustained at 6 months. So, and you can read all about it in the paper that's cited there, free of charge. You can get the whole thing. We're nearing the end of this presentation. I tend to go long, but I won't read each of these individually. We also collected qualitative data. I can't emphasize enough how important it is in psychedelic science to approach the science broadly and include inductive as well as deductive research methods. We need to bring the best of what science has to offer, the qualitative and the quantitative. So here's just a sampling of some of the statements some of our participants from this study made about their experiences. And it's interesting to note the months post-treatment in the second column. So I will pause and hope that gave you enough time to scan through it. My apologies for going so quickly. Where are we now? We're hoping for funding for larger studies with adults who aren't necessarily autistic. I think that's the quickest route to get MDMA approved as an indication to treat social anxiety. So treating everyone with social anxiety will also eventually benefit autistic adults. And just a word about diversity. My personal interest, for whatever reason, has always been making sure we get everybody on board as the psychedelic science ship prepares to leave the harbor and sail into the mainstream. Diversity really does matter. I hope that we don't put other interests ahead of helping the people who could really stand to benefit the most, often the most lacking in resources. But I find it interesting to consider, what would it be like to provide this therapy for deaf individuals? What skills would the therapist need to hone? What does it mean to provide psychedelic therapy for individuals who can't hear music? And there's definitely a need for additional skills to address populations that may have more difficulty getting these treatments. So I tend to go long. My apologies if I've gone over the time limit, but I look forward to taking any questions at the end. Thank you.
Thanks, Alicia. Truly fabulous. Let's hear Dr. Paul now, and we'll be back together in the end.
Thank you, Bia, and Alicia, fascinating work. It's a pleasure to be able to sit and listen and learn. And it does look like a very large effect, and the fact that it's durable for 6 months, again, something's happening with these short exposures that is amazingly impactful and durable. And I marvel at the fact that it's happening with your patients, as well as the patients with depression and other diseases that we're studying now. So my talk is on a study that we did here in normal volunteers, and I'll get back to what a normal volunteer really was. This was a phase 1 study of psilocybin that we did with collaborators here at the University of Wisconsin. And I wanted to kind of use this series of slides to sort of go through some of the steps that are a component of developing a drug from concept to FDA approval, which is the goal for not only the MDMA, but also for psilocybin, as we're working with it in multiple sorts of contexts. I did want to point out that I do have some possible conflicts that I wanted to be clear about. One is a little bit of work that I did with, that I'm doing with MAPS as part of the MDMA for PTSD pilot, and that's in collaboration with Dr. Christopher Nicholas and Randy Brown here at the University of Wisconsin. And also I worked a little bit with USONA on an investigator's brochure for a new psychedelic that they're working on. And I want to emphasize that there are multiple compounds, natural products, that have been looked at as possible components for a regimen or a portfolio, if you will, of psychoactive drugs for research. And I'm just going to be talking about psilocybin, and there's a lot more research to be done. So why psilocybin? One of the reasons that psilocybin is used is that it rather reliably establishes and maintains the mystical state that we're looking for. Some mystics can do it for minutes or seconds. We can do it for hours with the kinds of doses that we're using. And I think that most of the people listening in have a sense of some of the possibilities and the diseases that we can attempt to, not diseases in every case, but conditions that we can try to alleviate. One of the reasons that we're using psilocybin is that it's got a shorter duration of action than the psychedelic mystical doses of LSD, and so it is more amenable to an outpatient procedure where we can treat the patients for 6 to 8 hours and then send them home. And it also tends to be well tolerated, as we've seen from multiple studies. And so moving towards the development of psilocybin as a new drug that we would take to the FDA and request a new drug approval is a series of steps that I've listed out in this slide. They go from concept discovery, preclinical research in animals, and then various kinds of clinical trials. And so first of all, you have to come up with a concept for the product. And in fact, this is something that's already been done for us. We can look at some of these pictures and diagrams from Mesoamerica and understand that the concept of the discovery of the active ingredients in magic mushrooms represented in multiple ways in these figures has been known for thousands of years. And so cultures have known that this was something very powerful, very important to their culture, and also something that they, as you can see in the upper left, rather revered in many respects. So the concept and the discovery in many respects has already been done for us. Of course, Hoffman identified it in the 1940s, 50s. We started working on it. Then the next step is the preclinical research. And typically this is going to start with in vitro research, literally in glass. And ideally we would like to know what the site of action is, what the downstream effects of the pharmacology are, what the mechanisms of action are. And in fact, much of this was done in a rather rudimentary fashion in the 1960s and 70s, but now more recently in the 1980s and the early 2000s, we've got such more remarkable tools to understand where these drugs are acting, psilocybin on the serotonin receptor. But quite honestly, even though we know where they're acting, we don't really know how they're acting, why we can get such a remarkable mystical experience that arises from a serotonin-like drug, similar to other serotonin-like drugs, but in a fashion that is so very, very different from anything else that we might be using in clinical practice now. And then we also have I had intended to have a preclinical research slide talking about animal research. And I guess it's a little bit Freudian that it's not there. Typically, the animal research is intended to demonstrate safety of a product and the toxicology, the teratogenicity, or the likelihood that it's going to cause birth defects. And there has been such a large body of evidence in human exposure and human safety that in fact, in proposals to the FDA to use the psilocybin in a clinical setting, the typical animal work has not been required. And so, yes, there is some animal work that's been done in the 1980s, in the past 20 years, we'll say, but it's not in the same classical sort of fashion that's been required of other drugs, in part just because of the demonstrated safety, both in classical cultures, but also in more clinical research. So let's get on to some of that clinical research. We have phase 1, 2, and 3 kinds of clinical research, and I'm going to jump to phase 2. So phase 2 research is typically expected to assess the efficacy and the side effects of a drug. And we're typically looking at maybe 100 patients, but in many cases, it's going to be far fewer patients than that. And we're trying to demonstrate that there is a therapeutic effect of the drug. And I think most of the people listening will be aware of multiple studies that have been done and reported in the past several years that have demonstrated a dramatic effect of the psilocybin. And I've got a list of them here from the United States. Of course, Dr. Robin Carhart-Harris from Imperial College, also with some really remarkable results there in the UK. We've got 3 listed here, and Dr. Carhart-Harris's present study is at the top. He was looking at patients with treatment-refractory depression. First, a dose of 10 milligrams of psilocybin, and then 25 milligrams 7 days apart. There's a slightly different approach taken by the Johns Hopkins group, where they used a dose of 22 to 30 milligrams, and that changed over the period of the study. And that's an average, that dose was based on the patient's weight. So if I weighed 70 kilograms, I would have started out with 30 milligrams, and then they lowered the dose for various reasons. And then Dr. Stephen Ross and his colleagues at New York University had a standardized dose of about 0.3 milligrams per kilogram, again, around 21 milligrams. So we're looking at doses around 20 to 25 milligrams of the psilocybin in these studies. And again, we have some remarkable results. I'm going to just kind of mention a few of these studies to point out and reemphasize the dramatic effects that we're seeing. So here again, 12 patients with moderate, severe treatment-resistant depression. These are patients that are not responding to our best drugs for the treatment of depression. And you can see that at 1 week, there was a very rapid, quick drop in the Beck Depression Inventory that again was very durable. And you can see it in the right-hand slide as well, the individual plots of the depression scale. Very remarkable, very important results. This is the same plot that I showed you in the lower right, a little bit bigger, so you can see here the dramatic drop in the Beck Depression Inventory seen 1 week after the dose. And again, there were durable effects. Some patients had a gradual rise in their depression scores, and that raises one of the questions that we'll have to deal with down the road. And one of the things that I think is going to come up is, do we just give one dose for the treatment of depression, or do we have to come back and treat the patients at some other point at 3 or 6 months, maybe later afterwards? What kind of response do we expect in those patients? And should we do that up front? Should we give them a dose per month times 3, for example? I don't see that happening in the process of bringing this to the FDA and other regulatory agencies for approval. But after the approval, I think that that will be one of the major questions to ask, is whether or not we should be giving additional doses to try to increase the durability of the response in patients who did respond. And for those patients who didn't respond completely, perhaps we can get an additional benefit by additional doses. So looking at the Johns Hopkins group with Dr. Roland Griffiths, they had a slightly larger number, 51 adults. And here they had patients with a life-threatening disease, anxiety or mood disorder, a bit of a gemisch there. And then they used a double-blinded single dose of either a low-dose psilocybin or a higher-dose psilocybin. And the patients were then crossed over to the alternate treat at 7 weeks. So everybody got the high dose, and they actually were concerned that the low dose might be a little bit too noticeable, and so they dropped it from 3 to 1 milligram per 70 kilogram individual. And again, here we see that they had a dramatic effect. The first point that you see after the baseline is the effect of the high dose. This red line is the high dose result from in this case, the Hamilton D depression score, and then the Beck depression next to that. You can see that at the first assessment, there was a dramatic drop. And then the third time point listed here is post 2. That's after the second dose was administered, and you can see that the people who first got the low dose, the blue, had a dramatically improved result when they got the high dose psilocybin dose. That was consistent across the different scales that were used, suggesting that in fact there is a dose response to the treatment of depression. And then the New York University's phase 2 study, where they looked at psilocybin versus niacin, and again, life-threatening cancer, anxiety, and or depression. And so they found, again, some really dramatic results that are pushing the science towards phase 3 studies and hopefully a new drug application. However, one of the things that we've not done really is a tightly controlled phase 1 study. I've been showing you phase 2, does the drug work, kinds of clinical studies. But the FDA and the EMA are going to be wanting to see what kind of pharmacokinetics, what kinds of drug concentrations can we expect in this kind of dosage range. What are the effects of kidney dysfunction, or what is the effect on the heart? And so we decided that we propose that we take another look at that phase 2 work and back up and do a phase 1 study, looking at not only the doses that were being used at the time, but also higher doses, expecting perhaps that individuals with various substance use disorders might need higher doses, and are those safe? And the other question is, does the drug show dose proportional pharmacokinetics, or PK? If we increase the dose by 2-fold, do we see a 2-fold increase in the exposure to the drug, or something that is less or more than what we expect? And I have to give credit to Dr. Vollenweider's group. This is a paper first authored by Hosler, one of 2 that they wrote that really are really fine pharmacokinetic studies. And we are basically standing on their shoulders to make our phase 1 study work. You can see here the plots of the active metabolite, psilocin, and the plot that comes down very quickly at first and then comes down as the IV dose, and then the concentration of the psilocin given orally is that middle line, if you will. What you don't see in this plot, and one of the other reasons why I put it up there, is that you don't see psilocybin, because it is virtually immediately converted into its active metabolite, psilocin, and we can't measure psilocybin in the blood, we can't measure it in the urine, and so the psilocin, the dephosphorylated metabolite of psilocybin, is the active form. And this is a plot or a diagram of some of these metabolites. The other thing I wanted to point out is the psilocin, the second structure down, is also glucuronidated. And one of the things that we did not do, because we did not have a standard for it, and frankly the money to process it in the ways that we might have looked at it, is that the psilocin is glucuronidated. That is, a sugar is added to that molecule. And if you look at the plot from their work in 2002, the Vollenweider group showed that if you can enzymatically remove that glucuronide from the psilocin, you can see with that black bar that there's a lot of the psilocin that's present as a glucuronide that we're not sure what that does. We're not sure if it causes no effect at all, or if it has, in fact, a component of that hallucinogenic or mystical experience that we're seeing with the psilocybin as a whole. So that glucuronide metabolite also is going to be deserving some additional study down the road. And where do you get your psilocybin? We're not going out and giving people mushrooms. We're using psilocybin that's been synthesized. It is quite literally as pure as the driven snow up here in Wisconsin in a few months. Now, the material that most early studies, such as New York University and Hopkins, were using was synthesized by Dr. David Nichols in the red shirt. This is his retirement seminar series at Purdue. He's now in North Carolina, and he's the chair of the Hefter Foundation. His postdoc graduate student, his postdoc is Nicholas Cozy, who is on the right. And Dr. Cozy is back at the University of Wisconsin-Madison and is a fantastic medicinal chemist as well as a neuropharmacologist, and was able to synthesize the psilocybin that we've been using in our clinical study, as well as various other studies going on at Yale and elsewhere. So to lay out again this phase 1 study that we did at the University of Wisconsin, we did this not because the results of the Swiss study by Hausler and Vollenweider were done poorly, but just that there was not the control and the documentation, the rigor of documentation primarily, that the FDA and the EMA would require. And so we basically did this in what we would call good clinical procedures, a CGP kind of study, and had every piece of data audited by our local CTSA, Clinical Translational Studies, basically our research infrastructure here at the University of Wisconsin. We did 12 normal hallucinogen experienced adults, and the hallucinogen experienced adults caveat or expectation was done because we were going to be pulling blood samples over a period of 24 hours after each of 3 doses. We were concerned that the patients who in the middle of their mystical experience might look down and see the blood being pulled out of their vein and just go crazy. That was actually more of a concern of the Human Subjects Committee, the IRB, than us, but we put that in so that they had to have had some hallucinogen experience before, and a substantial experience. As it turns out, that wasn't a problem. People, in fact, were sort of gifting us their blood at the appropriate times, and so that concern was not really that it should not have required hallucinogen experienced adults. As it is the case for other studies of psilocybin, they have to go through a screening process to exclude patients who are at risk. And those patients who are on other antidepressants, such as the selective serotonin reuptake inhibitors, the SSRIs, have to either be tapered off or not be taking them to begin with. So after our initial screening, the patients would get the dose in the School of Pharmacy setting. They would stay for 8 hours with blood sampling during that period of time with additional needle sticks if our catheter failed. And then we walked them across the street to the University of Wisconsin Hospital Research Unit for additional pharmacokinetic sampling. And also we did some 12-lead electrocardiograms, ECGs, to look at the heart rate. We collected urine to look at the urine excretion of the psilocin and to try to correlate that with kidney function. And the other really important thing was that this whole process allowed us to create the infrastructure and the training for our current and future study guides. That was something that is also part of the legacy. Now, the pharmacokinetics of the drug is fundamental to what we were doing, and this is just an example of a kind of concentration versus time curve that we might be looking at with the psilocin on the y-axis and the hours after the dose on the x-axis. And we can observe from just the peak itself what the maximum concentration is that we achieved. And then by taking these trapezoids as indicated in the gray and then the orange, and then summing those up, we can get a sense of the area under the curve for the dose. And that area under the curve, or AUC, is sort of an averaged exposure of the drug that the individual has. And we look at both the Cmax, the maximum concentration, and that area under the curve to see if, in fact, we have a predictable and proportional change with changes in the dose. And so this is an example of what we did see. Here is the plot of the area under the curve. And you can see that although there is some noise associated with it, that as we go from a dose of 0.3 milligrams per kilogram, which is sort of the standard dose that was being used at the time, and escalate that by 50% and then double it to 0.6 milligrams per kilogram, that it's a nice straight line. And that's also the case when you look at it in the right-handed figure, where we're looking at the absolute dose in terms of milligrams as opposed to the milligram per kilogram dose. So this is what we wanted to see. We wanted to see that it was a proportional change as we went up in dose. We saw the same thing as well with Cmax. Again, some chatter, some noise, but in terms of the statistical analysis, this is showing us that it's a proportional increase. It's a well-behaving drug, and that we don't really see any surprises, even if we have patients who have unusually high exposures to the drug. One of the other things I mentioned we were looking at is the effect of kidney function. The measured creatinine clearance on the x-axis is an indicator of kidney function. And the psilocin clearance on the left is what we're trying to get a sense of. How much of the removal of the psilocin is dependent on the creatinine clearance. And you can see that there's a little upward trend here as we go from left to right, suggesting that yes, there is some role of kidney function on the removal of psilocin. But if you look at that R value of 0.21, 0.22, only about 22% of the overall clearance of the psilocin can be explained by kidney function. And the FDA, as it goes to registration of this drug, the psilocin as a new drug, will probably require that we go down to lower functioning kidney patients, down below 60 mils per minute, and just demonstrate what kind of pharmacokinetics we see in patients with impaired kidney function, as well as those patients with bad liver function. Those studies will probably be required before the FDA grants approval. However, one of the things to consider is that since we're just giving one dose, that the impact of bad kidneys or bad liver is not going to be as great as it would be if we were giving the drug on a continuing regular basis. And so it may be that we can do those studies later, but I kind of doubt it, quite honestly. Now, some of the adverse effects you may already be aware of from some of the reports from Hopkins and elsewhere. You can see here some plots from Roland Griffith's group showing that the systolic blood pressure, the diastolic blood pressure, and heart rate will go up in peaks around 2 hours. And it's not clear whether this is due to the pharmacologic effect of the psilocin, or if this is just part of the exposure that they're having, the mystical experience and the excitement that that's generating. So we really don't know if this is something that is more psychogenic or pharmacologic, if you will. And it does come back down quickly, back to normal. We have, as the other groups, a box of emergency medications that are intended to alleviate excessive anxiety, excessive blood pressure. We're replacing the haloperidol with risperidone in forthcoming studies just because of better, well, a couple of factors. But really, of these emergency medications, if you will, the only one that we've really had to use is acetaminophen, because patients tend to have a headache at about hour 12 to 16 after the dose of the psilocybin. So a little bit of acetaminophen seems to help with that headache. And in fact, it may be that we'd give that prophylactically in the future. Here are the tables of the most commonly observed adverse events that we saw. And remember that dose 1, 2, and 3 were escalating in an upward manner from 0.3, 0.45, and then 0.6 milligrams per kilogram, a doubling of the dose. And again, the 0.3 milligram per kilogram is the usual dose or close to what's going to be used in additional phase 2 and 3 studies. And you can see that there's really not an upward trend. You might expect that as we increase the dose, that the frequency or the severity of the toxicities goes up, but that's not the case at all. And that's really encouraging. This is also very encouraging results. And then the high glucose, I will point out, is most likely, we think, due to the fact that they were given as much dark chocolate to consume during their experiences they wanted. So that's explaining that, I think. So what's coming forward? Additional phase 2 studies in depression being led by USONA and Compass. Substance use interventions are underway as well. Johns Hopkins already underway with New York University, looking at alcohol. The University of Alabama with Peter Hendricks looking at cocaine and having some interesting results there. And then we've recently received funding from the Hefter Foundation to look at psilocybin in patients with opioid use disorder. So that's coming down and also going to be an exciting area to look at in addition to the depression. The phase 3 registration trials are going to be bigger. And again, they're going to be looking at effect, but typically they're going to be standardized against some sort of a placebo or an active control. And that's one of the other issues we grapple with, is how do you make a placebo when you've got a drug that is going to cause a fantastical, mystical experience? And it looks like, for the most part, niacin may be the one that we're using, but I think that people will know. It's perhaps the best that we can come up with. I've already mentioned the question down the road of one psilocybin dose versus monthly, but I think as we go into phase 3 trials, the registration trials that then will be presented to the FDA with the argument that it should be an approved drug, that we'll start with that and then move on to look at combinations, possibly monthly doses times 3 for patients to have a more durable effect. And again, I think that's going to be led primarily by USONA and Compass from across the pond. There's also phase 4 post-marketing work. So after the drug is approved, the FDA will probably require additional research, clinical research on the patients that receive it, looking at whether or not it continues to have the efficacy that they saw in the earlier clinical trials before it was approved, and then to monitor for the diversion or the possible abuse risk. I don't think that that's going to be much of an issue because we are handing the capsule to the individuals in the setting room, and so the potential for diversion and abuse is going to be very low. Safety is going to be one of their major concerns, and a REMS or a TASU are likely. And these terms, these acronyms, stand for a risk evaluation and mitigation strategy, which is applied to many drugs and could be just sort of a monitoring of sorts. But the TASU is something different, and that's the elements to assure safe use. That is probably going to be set out to codify or formalize, for example, the kinds of screening that is going to be required, the kind of training that the guides taking care of the patients are required to have, perhaps some oversight of what kind of setting that the patients are in. And that is going to be the expectation and part of the labeling of the drug, so that in order to use the drug, you're going to have to do it in this manner with the other infrastructure, if you will, in addition to the drug itself. And then one of the other points that I try to make a substantial emphasis on is the safety of the psilocybin. And I think many of the people here listening know that psilocybin in general, as is LSD, really rather safe in the appropriate context. There's no evidence that the LSD or psilocybin are addictive. And quite honestly, the side effects are fairly minor, as I've shown you from even a 2-fold escalation in the dose. So we have a fairly safe drug here, but it has to be used appropriately, and especially that individuals have to be screened and cared for in a very somewhat formalized fashion. The accidents and the harm seems to come from accidents and self-inflicted injury or just behavior that arises out of the sense that they are able to fly or jump out of windows without any harm. So that is one of the reasons why the individuals are screened, but also while they are attended for the entire period of the dosing interval of typically 6 to 8 hours. One of the other things that this kind of research and the success that's been had might make some people think that they want to go out and find mushrooms instead of the pure psilocybin that we're using. The concern there, of course, is that mushrooms may be the wrong mushrooms. They may be toxic mushrooms. But even if they are the psilocybin species, they may be adulterated. They may be adulterated with opioids like fentanyl, or they may be adulterated with PCP and other such things, making them far more dangerous than the mushrooms themselves would be. And so I just wanted to emphasize the kind of screening that the subjects are going through, the 2-hour skid that is administered to all of our patients as a screen, excluding for illicit drug use. We have 6 to 8 hours of counseling and preparation, which is also a part of the MDMA work as well. And then the qualifications. What kind of qualifications moving forward should the guides have? At least one of the people in that guide dyad. And those individuals need to be with the patient while they're under the influence of the psilocybin, and then the patient discharged to a responsible support person, that they're not just sent out the door and wished a happy day. Also very important to the success, but also likely the safety of the psilocybin use, is the next day integration session, where the subject comes back, meets with the dyad, and is able to discuss their experiences, work through any troublesome experiences or memories that they had to deal with. And that seemed to be very much part of the therapeutic benefit of the psilocybin experience, is that integration session that pulls it all together. And then finally, I'll point out, this is our setting. I wanted to thank Dr. Randy Brown, who's our physician, a study physician, Nicholas Cozy, who synthesized the psilocybin for us, Christopher Nicholas, the PhD psychologist, and his wife, Dr. Chantel Thomas, crucial components, as well as the study coordinators, Michelle Gassman and others, that made the study a possibility. But one thing that I want to leave you with, and if there's only one thing that you learn from my presentation about the University of Wisconsin setting, the place in which this kind of treatment should take place, is that the formal name for a badger den, which appropriately is the mascot for the University of Wisconsin, the formal name of a badger den is a SETT, an SETT. So the University of Wisconsin is glad to be part of the team of individuals around the world that's working on psilocybin. And I hope that you found the talk interesting and helpful. And I look forward to your questions. Thanks so much.
Hello, thank you. I want to thank both presenters. Realized I called Dr. Paul and Alicia. I just want to say that Alicia is also a doctor. Perhaps I take for granted because she's a close friend or a woman. We're all into looking more in attention on how we treat women and men in the field. This is a little bit in the spirit of our upcoming conference, Women in Psychedelics Forum, that Alicia will, or Dr. Alicia will participate in CIIS. I want to apologize for that, and want to make a few comments and ask Paul and Alicia to have a pen, because I'm gonna read questions in a row in the interest of time. So I just wanted to make a few comments of my own. I'm just incredibly, amazed by the care and attention that is put into this research settings. And I just want to throw this in there because I'm an anthropologist and my field of expertise is more ayahuasca, and I hang out a lot with people from the ayahuasca field and more indigenous and mestizo populations. And I think there's a lot of stigma about biomedical research or health research in these fields. And they tend to think it's this horrible reductionism that is kind of violating traditions. And when one hears more closely about the research, it's incredible evident on how much care and love and attention is put into details, and that the teams are highly concerned with ethical issues and with all the, several elements and how they interact and play. And I find it very interesting, and especially the report that Alicia made about all the different elements playing, thinking, worrying about gender issues, about sexuality, about who is, about taking into the perspective of the community on the research. It shows that there's also prejudice on the other side of the fence, that a lot of misinformation. So I think this is good for a wider public to have access exactly to this kind of detail, which appears less in conferences or publications. You're not going to be talking too much about everything that actually, is behind the scenes until you see that put out there. And I also just think that this is great to demystify a lot of stereotypes. For example, the idea that you would treat empathy with MDMA, or even this idea that there's a lot of trans folks in the autism spectrum, and maybe one thinks, oh, maybe they're trying to heal that, but it's on the contrary. It's a lot of people that have this identify as autistic, maybe, have less restrictions about self-image in a way that they maybe are more free to experience their transition. And so I like the level of detail. That was just a general comment. And I'm going to read the questions to Alicia and also just point out that I double checked with Brad that the word ableism is not some self-evident word, because I never know if it's just me or everybody. So maybe you can explain what is that. And I'm going to read here some questions to both of you. Okay. Jesper is asking, did any of the participants of the autism MDMA study have peak experiences? Also, by Jesper, what was the difference in the results with lower and higher dose of MDMA in the study? Brad himself is asking, pure and simple, is MDMA a true psychedelic? Is it mind manifesting? Then there's for Paul, can you say anything about how much the dosage, high dose of pure psilocybin used in the study is in comparison to fresh mushrooms? And Mikey, Shelley, and John want to know about Paul's and Alicia's suggestions about how to find work in psychedelic research. This is super in alignment with the spirit of this webinar. As this field grows, we want to encourage you for this career path. And we have also another question. Can you share something interesting about anomalies in the studies? And Mike is asking, with the importance of setting in mind, what are your thoughts on merging the clinical setting in which these drugs are currently administered with a psychologist, MD, and others on hand with a natural setting? For example, having a team present while the compounds are administered outside versus in a hospital room. And I just won't resist of making a little provocation to Paul because he mentioned that mushrooms can be dangerous and psilocybin can, is pretty safe. And, this reminds me a little bit of a paper published recently by Siddhartha Ribeiro in our book, Healing, Psychedelic Science and Scientists. I forgot the whole name of the book. It's a publication by Springer. But I think that this claims must be relativized, because it's a little bit like saying, you better have vitamins than fruits, or you better have cesarean than you have natural birth. I mean, I get it that it's good for, psychedelic research, and it's important to follow the protocols, that's mainstream science. And of course, this is a webinar on the science, and I understand your position, but I don't know if I would totally underline and perhaps, give you the chance to comment on this, or maybe just more largely on how do you feel about this topic of psilocybin versus mushrooms, because there's this kind of continuity and discontinuity between the substance and the plant, the mushroom, the fungi, and the active principle. This involves a lot of sensitivities, especially for people in traditional settings that use mushrooms. So maybe you can comment, and I hope you don't mind me asking. And I'm gonna, pass the word in order again. So you guys can feel free to comment each one, the questions you want. You don't have to answer all of them. And also, if you want to just do some final words, you feel free to do that. I mean, you have speak a little bit, like 5 minutes or a little bit over that, and then I'll round up, and we're aiming to close at 1:30. So first Alicia and then Paul. Thank you.
Okay. My first question is, could we go another 5 hours? You've asked about 5 hours worth of questions here, but I'll try to be brief. I love the question about MDMA as a psychedelic. I've been on phone calls where people have gotten in shouting matches and things have gotten heated about arguing, yes, it is, no, it's not. This is where I've landed personally. I think it's less reliably a catalyst of entheogenic and mystical experiences, but it can happen. There is a little bit of research published about gender differences in MDMA, and an earlier paper, I think it was out of the Vollenweider lab, suggested that females are more likely to report more classic psychedelic effects of MDMA than males. A later, larger study kind of refuted that, but I don't know if it was kind of an apples and oranges comparison. But I actually, last year in presentations, sort of challenged the audience. I posted qualitative statements drawn from both the psilocybin and the MDMA studies and invited the audience to guess, was this an MDMA participant or a psilocybin participant? And some of the statements about undeniably psychedelic, mind manifesting, entheogenic, spiritual experiences came from the MDMA participants. It's less reliable. It may be in part dose dependent. There may be gender differences that come into play. It might be related to setting. It might be related to their background regarding spirituality and so on. Classic hallucinogens are more reliable catalysts for mystical experiences. It doesn't mean it doesn't happen with MDMA, but they're qualitatively different. So that's kind of all I'll say on that. The low versus high dose, I think this is some of the most interesting findings that came out of our dose escalation study. And I believe it was Annie Mittover was one of the first to say or speculate that we might actually see better clinical outcomes in some domains with the lower dose. And that kind of got me thinking. That was based on what they were seeing in the PTSD studies. And then a sidebar conversation I had with Dave Nichols at a conference, he said people go on and on about serotonin and MDMA, but at the higher doses, even you have to take the dopaminergic effects into account with MDMA. And I've started thinking of kind of the serotonin-y dose. You have to come up to a certain level or a certain dose with MDMA in order to avoid that really uncomfortable kind of agitated feeling that feels a bit like you've had too much coffee. The dreaded underdose can be really bad. That's why I kind of laugh when people talk about microdosing with MDMA. Like, oh, I don't think you want to be doing that. But at that 75 milligram dose, when you get that increased availability of serotonin, in that state of calm and well-being and safety, the point Dr. Nichols made was SSRIs aren't happy pills. They don't make you feel good. And at that dose range with MDMA, you don't get the euphoric effects. People don't roll in that classic sense, but they feel safe. It's easier to establish therapeutic rapport. It's easier to connect with the therapist, and a different kind of work can be done in that state. When you go up into the higher dose range, say, for example, the 125 milligram dose, when you're getting some dopaminergic effects, that energized, like I would love to be able to talk to you right now, but I really just want to dance and fidget and squirm around and my thoughts are kind of racing. I'm having a hard time concentrating. If you think about it, that wouldn't be in an ideal state to go in and speak to your therapist you see weekly for routine psychotherapy, but it may have implications for people with body dysmorphic disorder, people who have had a hard time feeling at ease and comfortable in their body, potentially amputees, people with chronic illness. There may be another type of therapeutic value in that higher dose range. And for some participants, a combination of both. I think for naive users, starting at a lower dose as kind of a practice session and then going up to a higher dose is indicated. One thing that psychedelics are really demanding clinically is an individualized approach to medicine. And, you know, the pressures we get in the Western medical model is kind of standardizing to find the treatments that work for most people. But I've always kind of been interested in the outliers, the people on the fringes and what we can do for them. Let's see. A word about anomalies. It's a known phenomenon that there are some people speaking about MDMA are classic non-responders. Our last participant in the study had reported no subjective effects, and there was no change in the vital signs, no increase in body temperature, no increase in heart rate, blood pressure was stable throughout. And we were so convinced, Dr. Grobe and I both record our belief of condition of assignment after the treatment sessions, and we both reported very certain that they received placebo. And when we broke the blind 6 months later, we were obviously a little freaked out about that. So what in the world happened? Could there have been a randomization error? What could have gone wrong? We were so surprised by the result that I requested an ad hoc analysis of a blood plasma sample, and sure enough, there was MDMA in there. So this is a critical area of future research. I've spoken to some of the clinical team at MAPS, and this non-responder phenomenon is a known thing with MDMA, and there are kind of two major areas of speculation. Is it genetic and related to metabolism? Are they ultra rapid metabolizers and the liver's just making quick work of the MDMA and getting rid of it? Could it be related potentially to concomitant prescription medication, or more specifically, people with a history of using SSRIs? There's some early signals that might be the case. And although our participant had been off prescription SSRIs for a full 2 months before treatment, there seems to be, just based on, preliminary look at the data and anecdotal accounts, there seems to be some correlation with prior SSRI use. So that's important to look at that with more in future research. I'll pause in the interest of not hogging up all the time to comment on clinical versus naturalistic settings, but I have some observations on that topic as well. But I'll pause now.
So in the terms of the setting being natural or constrained, I think as we work through in human subjects committees and IRBs, there is a concern about being able to control the individual as they're under the experience. And I think that for the time being, we'll probably have a somewhat constrained environment. There's also the question of the mushrooms versus the pure psilocybin. One of the things with the mushrooms is that we don't know exactly how much they're getting, with a given amount of mushrooms, and the amount of psilocybin is going to be a function of how much the mushrooms weigh. Are they dry weight? Are they wet weight, newly harvested, where they were grown, and so on. So we don't have that consistency that is required to have a sense of what the dose is doing. And certainly in the context of my work of the pharmacokinetics, one of the fundamental things that I need to know is exactly how much they got in order to look at the clearance of the drug. Having said that, I think that we're looking at the development of a drug that I think very, very positively is going to at some point be approved by the FDA. And once it's approved by the FDA and has demonstrated by that approval to have a legitimate medical use, even though they may think that it has abuse potential, it will no longer be Schedule I. It will no longer be an illicit drug. And at that point, I expect that the possession of mushrooms that one would want to use therapeutically or recreationally will no longer be facing the kind of criminal implications that it does now. I can't really say. Certainly, I've not had any experience with either. I don't know that the mushrooms are going to be better than the psilocybin or worse, but I think that it will be much easier to find out once we get the psilocybin approved by the FDA and the EMA. The other issue is also, once it's approved, I think, and we have a better sense of, with the hundreds of people that are going to be required from a phase 3 study, we'll have a better sense of how important the setting is. It may be that the setting is a part of the therapeutic component of the action of the psilocybin. And then the question is, do you gain or do you lose some of that therapeutic component by having it in an uncontrolled natural setting that may have some distractors and may actually have some unintended dangers?
Hi. Well, I enjoy your answer, and I'm going to jump in and make another one then. So this touches another hot topic, and again, I'm not a scientist, I'm an anthropologist, so I talk from the perspective of my discipline. There's a discussion on whether therapists should have firsthand experiences or not when handling substances to others, and what I understand is that the MAPS protocol has won the right that therapists can have one legal session with MDMA, but that's optional. So I just would, ask both of you, what is your perspective? So Paul, you just said that you never had experience with any. What do you think of this? Would that be desirable, or do you think that maybe ethically that is complicated, or on the contrary, it's kind of complicated not to have a first-hand experience? And then I'm just going to expand to the other continuation of the question is, why do you guys do this research? Why do you are involved? I was making fun with Alicia the other day that somebody wanted me to sit in the underground setting, and I said that I didn't, I couldn't imagine sitting 12 hours waiting somebody to have an experience, or 10 or 6 hours or 5 hours. And I wonder if I could be in my computer, reading my emails, and but a lot of people made fun. So it's obvious a kind of talent to want to be sitting to give substances, and whatever you want to say. Why do you do this research? So again, for the both of you, do you think first-hand experience is important? And why are you involved in this research? Why do you ultimately chose to do that? And let's go in order, Alicia and Paul.
Well, as time goes on, my answer to the first question about whether it's important for the people in the room to be experienced, it's evolved and changed quite a bit. The deeper I go into doing this work, the more I think it is important for clinicians to know the terrain. Oftentimes we resort to analogies saying you wouldn't want to climb Mount Everest with a Sherpa who'd never climbed the mountain and hangs out in the base camp, no matter how many manuals and conversations they've had with others. I think it's so dependent on set and setting and the indication, the health of the individual, the reason that they're using the substance. I think in more clinical settings, if you're dealing with more serious mental illness or in higher risk situations, I think there's a stronger case for the clinicians to have experience and to know the terrain. We're frequently asked, it just came up again in a focus group. We did a focus group for the long-term survivor study, and part of the feedback they gave, it really kind of speaks to not really the golden rule, but would you want to take a high dose of a classic hallucinogen or MDMA in a room full of people who'd never done it before? There's a measure of safety and comfort for the participants, knowing that the clinicians have had their own personal experiences. My kind of cautious qualified answer is I think it needs to be assessed per the situation, per the setting. And I don't think it's always absolutely critical that everyone in the room have had their own experiences, but I think it definitely enhances the toolkit of clinicians who are working with individuals with more challenging presentations, if that makes sense.
Yeah, I just wonder if you could say why did you choose this career path, or why do you do this work? Maybe in one line.
I was reading this book and came across some testimonials by young men who self-identified as having a schizophrenia diagnosis, and their testimonials were so compelling. I was reading this book because my coworkers were doing ecstasy, and I was afraid they were going to destroy their brains. And I was so moved by how powerfully transformative MDMA was for these young men. I just had to find out why these tools weren't more readily available to people who were suffering, and wanted to be a part of figuring out whether or not it was safe to provide therapy with, access to these medicines. And I'm involved because I think they have the potential to hurt people, to help people who are hurting the most. And I think it's very important to do that in careful, measured steps to find out how to do it safely.
Wonderful. Let's hear Paul towards the end.
Okay, thank you. So why am I working with this? Initially, I was drawn in because we were thinking very much towards looking at it for the treatment of patients with end-of-life issues, anxiety and distress, and I think that still is going to be one of the first indications for psilocybin in treatment-resistant depression, depression associated with severe illness, or just primary depression. It's going to have a huge impact on a lot of people. So it's very important, whether it's from the cancer patients that are the primary focus of my clinical work or not, it'll be huge. In terms of personal use, I think that there are some strong arguments for it. One can, and then one gets into the question, how many other medication classes should we expect the prescriber to have taken? For example, I don't expect the oncologist to have had some cyclophosphamide before he administers it to a patient with breast cancer. That's a little bit flippant, but this is a unique expectation that the clinician or the prescriber has actually taken it. But there's another issue that I'm still holding to. I think it would be curious and helpful for the investigators to have had this experience, and quite honestly, I think some of them have. But I think that the argument can also be made that if I can be a strong advocate and promote the science, promote it politically at the point where it becomes necessary, I think it may be helpful for me to have that credibility of not having taken the medication before and yet still having such a strong confidence in its merit and its safety.
Wow, very interesting. I like that. Definitely, there's things that could be said. For example, you don't need to have a homosexual experience to advocate for gay rights, or you don't need to have a trans to be able to defend Afro-religion cults or religions or expressions. It's definitely a huge topic. This inspires us for next webinar, and I also hope that Alicia, you guys hurry up that study in UCSF, because we're all dying to know, not to play with words, but what are you finding out? I know from potlucks and hanging out in the Bay Area that it sounds really promising, and that the results that you're finding so far are very encouraging. I just want to double congratulate both of you and thank you for your work, for your bravery, to give strong substances to people that are in need, or to people that are just experiencing it. And it takes a lot of guts to do that. It's much easier to take other career paths, and it's harder to open the paths than be the first ones doing this research out there, because there's a lot of things that are up in the air. And thank you for your goodwill in answering all questions and all that. So we're going to round up here. I want to invite everybody to come to the next webinar. That's going to be November 7 on the same time. The topic of the next webinar is how to become a legal MDMA therapist, and it will be given by Shannon Carlin and Sarah Schell, both from MAPS. And we're also interested in your constructive feedback if you want to give ideas of topics or just remarks on where we can take the series or how we can improve it, you can either write to webinar@maps.org, or you can write directly to me, BIA, B-I-A, @maps.org. I also want to take a minute and a liberty to invite people, if you're interested, we're organizing an ayahuasca retreat for healthcare professionals that are involved in psychedelic research or want to be involved in psychedelic research, where we're planning exactly to, offer firsthand experiences and talk about it and have this kind of philosophical issue. So it's a personal interest of mine. I'm trying to do this bridge between the world of plant medicines and the world of psychedelic science. Obviously, the grounds in the US are limited for this kind of experiment. So I just want to leave the invitation up in the air, and also ask you, if you want to visit our site, chacruna.net. Alicia has published an excellent paper there about ethical issues in relationship to fundraising and to media, and how to conduct research in public. And there's many other awesome articles over there. You can join our newsletter at chacruna.net. I also invite you to join MAPS newsletter at our website. And see you next Wednesday. Thank you very much, and keep on tuned in our webinar series. Big hug from the Bay Area, and also much thanks to the whole team behind the screen, all the tech people and marketing and all the other, Bryce, Brian, Cynthia, and others. See you later. Thank you.
Thanks so much, everybody. We'll see you next time.
Bye.